Okay, so this is Chapter 33, Pediatric Emergencies. This is the continuation. This is Part B. We're going to start talking about shock in kids. So kids tend to compensate for any injuries or anything that's going on for a long time, and they'll appear to be okay because their compensatory mechanisms are so good, and then they'll compensate and compensate and compensate, and then all of a sudden they can't compensate anymore, and then they just crash. Whereas adults have, kind of a more gradual decline, a more progression can be seen the whole way off. So just because your kid looks okay, don't rule out that they're have some internal injuries and are compensating well. They need transported usually quickly. So here's some common causes of shock in pediatric patients. Diarrhea and or vomiting, if this goes on for a few days, and they can't take any fluids in without vomiting them back up, which sometimes happens with kids. They're going to eventually get super dehydrated and hypovolemic, and they'll need an IV fluid replacement. Infections can cause shock, trauma, especially injuries where you're going to get possible damage to those abdominal organs and bleeding out inside. It doesn't take a lot of blood loss for kids to go into shock. Sometimes kids find out the hard way that they have allergic reactions to things, nut allergies or bee sting allergies, that kind of thing. Poisonings are often accidental with kids, getting into something they shouldn't be getting into. Cardiac events are fairly rare in kids unless they have some kind of congenital thing going on. So signs, symptoms of shock for kids, similar to adults, but we're going to add apathy or lack of vitality. Kids don't just lay there like lumps and stare off into nothing. That's a sign of shock in a kid. They're not necessarily tired or something. If the parents describe them as just being tired and lethargic all the time, that's a sign of shock. Pale clammy skin, altered mental status, just like with adults. Absence of tears when crying might be a sign of dehydration. Falling blood pressure sure would be a sign of shock. We're not going to monitor blood pressures quite as frequently with especially the little guys, as it's just really hard to get manual ones. If you use the smallest cuff with a monitor, you might be able to get a decent blood pressure on them. And then cap refills you can check on kids. Remember that their head is really big, and they can have head injuries. They'll get foreign objects in their mouths, listen for wheezing in their lung sounds. If there's any kind of trauma involved, check during your head to toe for instability of that pelvis. If the kid is unconscious after a car accident, make sure you're protecting that C-spine. Remember, these guys and gals are susceptible to hypothermia due to that greater surface area to mass ratio. So if you can at all, cover their head, cover their body, keep the patient compartment warm. It should be uncomfortably warm in there for you, but that's what the patient needs. Avoid rough handling, obviously. If you are worried about active rewarming, if you think they're really truly hypothermic, then you can consult medical control. You can use our chemical heat packs. Just keep something in between that and the patient. Don't put those directly on the skin. Okay, we're going to switch to talk about some common medical emergencies in kids. So if a kid is in cardiac arrest, it's almost always due to a respiratory issue. So either they choked on something or drowned or something else was going on that caused them to not be breathing anymore. So worry about getting that respiration back. Give them lots of oxygen. Kids can deal with excessive oxygen. They can't deal with a lack of oxygen. They are more O2 dependent. So again, these signs of breathing, of signs of difficulty breathing, nasal flaring, retractions, excessive use of abdominal muscles. Remember, they are abdominal breathers. Stridor, that wheezy sound coming from the upper airway. Grunting, kind of where they're trying to keep their lungs a little more open by not letting out their breath fully. And then abnormal breathing rates, especially greater than 60. Altered mental status, sometimes it's harder to tell when it's not your own kid what is normal and what's not, so ask the care provider. Cyanosis is a bad sign, whether you're an adult or a kid. Decreased tone, poor peripheral perfusion, these are all signs potentially of breathing difficulty. Remember, with kids also bradycardias are associated with low O2. So upper airway versus lower airway. Upper airway is basically from the epiglottis up, and so that's the mouth, throat, and larynx. Most commonly here, we're dealing with foreign body obstructions. A kid swallowed something they shouldn't have. But other less common things, trauma, swelling from burns or infections. If they have difficulty breathing or stridor or speaking, that's what their chief complaint might be. Lower airway stuff, this is more your asthmas, pneumonias, other infections. You're going to figure this out with their lung sounds. Croup is a pretty common illness. There's going to be some fever and a sore throat. But they have a seal barky cough and difficulty breathing. Probably some paleness, maybe a little cyanosis. This often gets better with some cold air. It kind of opens those airway passages up a little bit. So you might carry them out to your ambulance, in the cooler seasons, and then they might do a little better after having been out in the air. Epiglottitis, this one is associated with a sudden onset of a high fever with painful swallowing because it's their epiglottis that's inflamed. They'll often kind of be sitting forward drooling in a tripod position. These kids look sicker than with the croup in general. The big thing here with these kids is you do not want to stick anything in their mouth, and you don't want to touch that inflamed epiglottis because it can cause that epiglottis to suddenly spasm shut, and then they can't breathe at all. So don't stick anything in the patient's mouth if you suspect epiglottitis. Fevers are a fairly common complaint in kids. So if they're over temperature, we don't need to try and keep them extra warm. So if they're wearing excess stuff, jackets and blankets and stuff, we can take that off. If you're really worried about a high fever, so in like the 103 range, you can start trying to do a little more active cooling things like a towel soaked in not cold water but tepid water. Make sure that they're not getting hypothermic from your over-aggressive treatment there. We generally don't give kids water on the way just because we don't have it in the ambulance. We don't do submerging in cold water for kids. You don't want to aggressively overcool them. So again, we're worried about high fevers here in the 103-ish range. Meningitis, so this is an inflammation of the lining around the brain or spinal cord. So signs and symptoms here can be fever, stiff neck, and aversion to bright light. These are kind of the differential diagnosis here for meningitis. Those don't usually come with too many other things, and they'll be real sick looking. Depending on the meningitis, this can come on fairly quickly. Also, depending on the meningitis, this can be reasonably contagious too, so watch out for these patients that way. Use your PPE. For the meningitis, treatment-wise, monitor your ABCs, vital signs, give them oxygen, ventilate with a BVM if necessary, watch out for seizures. Diarrhea and vomiting, again, this is a pretty common complaint with kids. If the kid's looking lethargic at all, they need to be transported or at least seen at the hospital if the parent's unwilling to let the kid go in the hospital or in the ambulance. You should at least get him to the hospital in some way. Seizures. So with kids, the first time they ever have a seizure, you should always get them transported. Lay them on their side if they don't have a spinal injury. We'll often get called for febrile seizures. So these are seizures associated with a fever. I've also seen it just kids taking like an especially hot bath. Parents have described some kind of seizure activity with that. Febrile seizure is usually not something to worry about, but anytime it's the first seizure that this kid has had, they should get transported and assessed by a doctor to make sure it's nothing more serious than that. Watch out for vomiting, maintain that open airway, give them oxygen, transport. In general, for altered mental status, just figure out what went wrong, right? Figure out the mechanism of injury. Watch out for signs of shock. Watch for the fall off the cliff. If nobody knows what's going on, maybe poisoning could be something that somebody hasn't thought of. So look for open bottles, that kind of thing, for poisoning. If there's somebody around that knows medical history, possible diabetes or seizure disorder, try and figure that out. For poisoning cases, go ahead and call contact poison control. Figure out what it was that they ingested, how much, and poison control out there on scene can tell you what the appropriate treatment is, whether or not you should give anything else, water or milk or something like that. They're almost never going to have you induce vomiting or anything, but it's appropriate to do what the poison control people tell you to do. Transport as needed. Sometimes poison control will say, well, that wasn't anything to be worried about. Continue to reassess. If the patient is unresponsive, make sure you're doing your ABCs, give them oxygen, rule out any trauma. It might have been a traumatic accident instead of poisoning or in addition to. For drownings, we're going to basically treat this like any other CPR case if the patient is unresponsive. Protect the airway. You might need to do more aggressive suctioning. If there's any chance that they were hitting their head on the bottom of the pool or something like that, or fell into and hit their head anyway, consider spinal immobilization. Protect against hypothermia. Keep them warm. Stop any bleeding, treat trauma as you can, transport. SIDS, sudden infant death syndrome. This is something that affects kids usually up to about a year, 18 months, and it's not terribly well understood, but it's basically kids are put to sleep and for some reason stop breathing and die in the crib. So these are the do's and don'ts for parents. Usually SIDS is associated with the kid getting caught up in blankets or something, and that's how they end up dying. So we get these calls, and we're going to do CPR, just like any other cardiac arrest patient. We're pretty much going to resuscitate every time, or attempt to resuscitate every time. It's reasonably rare there's going to be rigor mortis on scene. By the time we get there, it's typically best to transport, do CPR, and get them to the hospital where there's more support both for the parents and for the resuscitation. Okay, it's pediatric trauma emergencies. In motor vehicle collisions, kids these days are more often than not appropriately restrained, and you'll find them in their car seats, and often that's actually a decent way to transport them into the ambulance, is just to unbuckle that car seat from the car, put some padding in between the kid's head and the side of the car seat so that it kind of restrains them in place in their car seat, and you can use that to transport them then. Unrestrained kids in cars can have any kind of injuries at all. Heads, necks, abdominal injuries, spinal injuries, any kind of fractures, internal injuries. Especially watch out for internal injuries caused by lap belts and stuff. We'll talk about injury patterns. Make sure you're looking for any injuries to the head. Look in their eyes. Check their pupils for pearl. Examine the neck. Feel their chest. Look for symmetrical chest rise. Any crepitus. There's lots of important organs underneath there that could be damaged, so pay attention. Listen for lung sounds on both sides. Palpate their abdomen. Just a review of all the different organ locations in there. Kids can end up with some internal bleeding, especially like spleens and stuff. All the little ligaments and stuff that hold all their organs in place aren't just as well developed as an adult, and so you can end up with organs sloshing around, sliding a little bit more than normal, and having internal injuries during especially car accidents. Give their pelvis a squeeze, make sure it's stable. Examine each extremity, arms, legs. Feel down their back, just like for an adult. Checking for tenderness, any pain. Kids can go into a KED. Smaller ones, it's big enough to be just about like a long spine board for a kid. You just have to roll up the sides of it a little bit and perhaps use some tape to secure the thing around the abdomen instead of the straps. Burns for kids can be especially life-threatening. We're going to transport all of our patients to Gritman, obviously, but they'll evaluate whether they need to fly out to a specific burn center. For burns, just like adults, we're going to do dry, sterile dressings. We don't do moist stuff. We don't do any oils or any of the homebrew kind of remedies, butters or creams or anything like that. Make sure the airway is open, suction is needed. If there's any indication for trauma, do spinal mobilization, they need quick transport. So this is a review of the rule of nines for kids. Remember the difference is the head is 18 for kids, where it's 9 total for adults, and then the legs count as less. So each leg is 7 front, and 7 back. Child abuse and neglect. So unfortunately, this is something that you may encounter anytime anybody is dependent on somebody else for care. There's a potential for abuse. So things to look for: slap marks, bruises. Kids normally are going to have some abrasions from running around and stuff, but they shouldn't have a lot of them. Lacerations are less common. Multiple broken bones without good explanations why. Head injuries, abdominal injuries, bite or burn marks. These are all signs of possible abuse. Look at the adult or caregiver. See if they have inappropriate, either too little or too much concern about what's going on. Obvious issues with anger control, perhaps deep depressions, drug or alcohol abuse, suicidal thoughts in the adults. Make sure that you're providing some, modesty, comfort for that kid. Just like with adults and sexual abuse cases, we want to try and preserve as much evidence as possible, and they need to be transported. Our role in this is to be as objective as possible, so especially in your documentation. You can document conditions, what you see, what you observe, but don't try and put a value or a judgment beyond that. We need to report any suspected child abuse on to the hospital staff, that ER doctor. Failing to report is a misdemeanor offense in Idaho. When you're doing your reports and then talking to people, use terms like suspected and possible. Don't jump to the conclusion or use the label that's not appropriate. And again, our job is to report on to doctor, nurse, law enforcement if they're on scene there. If you do have a parent that is also a danger to themselves or others, then you're going to need another ambulance to come and check out that patient, and perhaps additional law enforcement if they're not already there. All right, some infants and children with special challenges. So we're able to keep alive premature babies a lot longer or a lot earlier now, or even earlier. So that might be a thing you encounter. Some kids do have congenital heart issues, or neurologic diseases, or some other chronic genetic condition. Something you might encounter an issue with is a tracheostomy tube. So that's going to be, a tube in the throat that they can breathe through. Could be occluded, might be an obstruction there. There might be not a good seal, air leaking around it, might have become dislodged. So there's a picture of one. You can suction that just as far as you can see if it's occluded. Otherwise, you can use like a very small bag valve mask to seal over that and give ventilations through it if necessary. Home ventilators are a thing. If you encounter one of these things, there's probably going to be a manufacturer's help phone number on it. If somebody hasn't called that already, that's a good resource for you. Otherwise, the parent or in-home caregiver is going to be your best resource on how to operate any kind of artificial ventilator. Central IV lines, your goal is to just not pull those out. They're not for your use. Gastronomy tubes, these are feeding tubes. Treat that patient mostly like any other patient. Make sure that you're not pulling that tube out. ABCs, transport so that you don't muck with the tube. In patients with shunts, make sure they have an open airway. You can ventilate with normal equipment. Transport them. So we don't deal with kids on a very frequent basis, which is a good thing. But it also means that these calls are typically more stressful for the EMTs. So especially EMTs that have kids can identify that patient with their own children. I've seen that. In general, it's just it seems to be a headier responsibility dealing with somebody else's kids instead of an adult. And so people might not feel up to the task, especially because they're low frequency calls. And calls where there's kids that are really sick, abused kids, or when the kid dies, those are really stressful calls. So remember that as with anything, the more you do it, the better you'll get at it. So extra training for pediatric style calls is good. You can talk with other EMTs. You can talk with a counselor if that's something that would help. And all the regular ways of dealing with stress. So your exercise, your good diet, getting sleep, avoiding stressful other situations. Okay, that's the end of this lecture.